Hey everyone, welcome to another episode of the Autonomous Health Podcast. This is your host, Anmol Madan, and today with me we have a special guest, Dr. Thomas Insel. Tom is a noted psychiatrist and neuroscientist, the chairman of Vanna Health, and the former director of National Institute of Mental Health, NIMH. He's the author of Healing and a frequent writer on behavioral health and the challenges surrounding it. Welcome, Tom, to the podcast.
Anmol, it's a real pleasure to be with you. And gosh, if we're going to talk about AI, I hope I can get you to do a lot of the talking because I learned from you more than I have to teach.
Yeah, we'll sort of exchange on that, Tom. But maybe, you've got such an incredible career spanning, I would say, over 4 decades now of working in behavioral health. And I think you've seen many different generations of that innovation. Tom, do you want to take a minute and just talk about your journey? And I think, some of the experience you've had very inspiring to people who are listening to this podcast.
Well, thank you. I'm not sure this is inspiring. It's certainly nonlinear, and it's not a journey I'd necessarily recommend to anybody else, but I'll quickly take you through it.
Yeah.
I trained during the psychoanalytic era, so back in the 70s in psychiatry after going to medical school, and trained at UCSF, which was a very psychoanalytic setting. It was at the time when medications and the whole revolution of biological psychiatry was just taking off. And so when I left my training and I went to the National Institutes of Health in Bethesda, Maryland, which was absolutely ground zero for that revolution. And it was just an exciting time to be in a place where people were beginning to use different kinds of tools, beginning to think about the brain and the biology of mental illness. So really a pretty fascinating period of history. I have to say that with hindsight, I'm not sure that revolution delivered in the way that we had hoped it would in the early days. It was a pretty good period for the pharmaceutical industry. I'm not so sure it was so great for a lot of patients. There were certainly progress and good stories to tell. But as you follow the narrative through the 80s and 90s, what you see is actually a lot of the public health outcomes got worse, not better. My own journey was to kind of leave the field altogether. I went into neuroscience, helped to launch a field called social neuroscience. I was very interested in neuropeptides, oxytocin, vasopressin, what they did for behavior, how they worked in the brain, and trying to understand the molecular basis by which they increased affiliation and attachment. And I worked on that for a couple of decades. Ended up being asked to take on the directorship at the National Institute of Mental Health, NIMH, which was really the major institution or agency for funding research in the science of mental illness. And I did that for 13 years. And it was at a time really when the genomics and neuroscience revolution were kind of delivering for much of medicine. And I guess I have to say that my great hope was that they would do the same thing for people with serious mental illness. I'm not sure that I would say that they've done that. And it was partly out of that frustration that I left to go to Google in 2015. Got really interested in a company that you were starting.
Yeah.
Just started, I guess actually we had funded it at NIMH, Ginger.io. And that was actually that experience of working with you and thinking about what we can do with technology got me really thinking, wait, maybe we need to meet people where they are. We need to kind of identify ways of engaging people, because a huge part of the problem was, although we had great opportunities, great stuff to offer, it wasn't getting adopted. And so the question was, how do you get through that implementation barrier? And that's where the technology and revolution, which I'll call the third big wave, really seemed to have promise. And this is after the genomics wave and the neuroscience wave. And now to be able to think about what software could do, what social media could do, what the various platforms where people were really engaged. And at Google, to know that I could put out something on search that would be seen by 100,000 or pretty quickly 10 million, 100 million people within 24 hours, which is what happened when we first put out those little health notices where we'd ask people to take the PHQ-9. And within a weekend, we had millions of people filling out the PHQ-9. So it gave us a sense of scale and a sense of opportunity. But I have to say, it's been 8 years that I've been in the digital mental health space. Much of that time thinking about what AI could do in mental health. We still have a long way to go. And the reality is, got new suicide numbers last Friday from the CDC. The number is going up, not down. And when you look at many of the outcomes that matter, levels of employment, levels of homelessness, likelihood of incarceration for people with serious mental illness, all the numbers are going in the wrong direction over these last many, many years. So we have a lot of work to do
Yeah.
to figure out how are we going to really bend the curve on morbidity and mortality for people with these brain disorders. Whatever we've been doing, it just hasn't yet paid off for those folks. And there are 14 million of them. So it's not a small problem.
So, Tom, if I can capture something you said there, right? So it's basically, would it be fair to say there's been 3 waves and now we're at the start of a 4th? And so there was the pharmaceutical wave maybe in the 80s. There was the genomic data and new kinds of personalized, maybe mental health after that. There was a digital mental health wave where we were able to create digital experiences around coaching, therapy, psychiatry, medications management, and maybe that's the most recent wave. Are we starting a 4th wave, which is the wave of AI and language models coming in and changing behavioral health? Is that a way to think about the next kind of 5 or 10 years where we are?
Yeah. So this topic is really hot right now. I mean, this is probably the, I don't know, 4th or 5th conversation I've had about AI and mental health in the last 7 days.
Yeah.
And so everybody wants to talk about it. And I do think it's going to be a wave. I think it's going to transform mental health as we know it. In fact, in all the areas of medicine, many will be affected by AI, just like AI has already had a huge impact on the way we buy stuff, on the way we navigate in our cars. I mean, we're already deep into that wave in so many other areas of our lives. We just haven't yet begun to adopt this for healthcare. I think when that happens, and it's going to happen quickly in some places, I think mental health will be the area that will have the biggest impact. And I say that because so much of AI in the way we think about it today is about language. It's about how we either analyze language, what we can take from language with natural language processing, how we actually are able to put a layer of objective measures on language in a way that is very different from our subjective perception of them. And now increasingly with generative AI, the way that we're able to produce language, and that is, gosh, when you look at what is mental health care, so much of it really gets captured by those 2 parts of a closed loop. It's as a provider, what you hear and see and what you deliver. And yes, some of that might be medication, but a lot of it really is the communication.
Yeah.
So I think there's every reason to think that so much of that is going to be transformed. Of course, AI is going to have a big impact on ophthalmology, on radiology, on many other areas, but they all have procedures and surgeries and things that are interventional, which most of mental health doesn't do. So this is why I think there's a big story to tell here. But let me tell you, I see this, I guess, a little differently than a lot of people. Every conversation I have immediately wants to talk about chatbots and how we're going to create avatars that will be therapists, that will be empowered by huge amounts of information and be customized to every interaction and be much more effective or as effective as a very good therapist. Maybe. I mean, I don't discount that. And I think it's a super interesting hypothesis. But right now, I don't think that's the problem that you want AI to solve. Not yet. Maybe that's coming soon. I think a more interesting set of problems are much less sexy, much more prosaic. And it's the stuff that really gets in the way of providers of mental health, behavioral health care. It's the boring stuff. It's writing reports and summaries. It's documenting what's happening. It's filling out forms. It's the billing process. It's all the office back end stuff. And I think the first part of this wave is going to be fixing a lot of that. So when I work in a company that deals with very complex patients who've had scores of hospitalizations and ER visits and may have electronic health records that would be the equivalent of an encyclopedia. They might be 5, 6, 8 volumes long. to be able to use GPT-4 and say, give me a 400-word summary of all this stuff, and to get that back in 5 minutes or maybe even 10 seconds, instead of taking 3 or 4 hours of sifting through all this. And then if you don't see what you want, to be able to follow up with additional questions and prompts. That's really, I mean, that's not a really sexy thing, but it's super important. The ability to use a digital scribe, so that with every interview that we would do with a patient, you have a summary at the end, and that summary can be informed not only by what the patient said, but with what you said, and even more importantly, by objective measures of how people said what they said. So, you did this at Ginger, but you capture things like sentiment, capture coherence, capture anxiety, stress. All of that is implicit in the communication. We make judgments about that subjectively as clinicians, as providers, and master clinicians are really good at this because they listen not only to what's said, but what isn't said. But machines are surprisingly good at being able to provide objective data on mood and anxiety and cognitive features and all of that stuff, which is just fundamental to an assessment of a mental health patient. What we do today, I call it telehealth 1.0. We throw all that away.
Yeah, I think that's great, and I think the way I've often spoken about it, and I think you're absolutely right. There is the first order operational process. Are providers spending their time on the highest value tasks, and are we eliminating the friction? A lot of the operational friction inside healthcare that exists, not just in behavioral health, but I think the same challenges exist in a variety of other conditions and primary care as well. So that's obviously a great place to start. I think the other place in mental health, which I would say, I feel like both of us have been involved in different projects over the years of different kinds of novel sensors helping form a better understanding of what characterizes a diagnostic decision and what's a PHQ-9 score represented in terms of a person's behavior and the patterns that underlies in sort of day-to-day life being measurable now using smartphones and sensors. I think that's been a journey that has been ongoing for the last decade and almost has, there's some benefits of language models there, but certainly it's been ongoing because of language models. I think the problem with computer scientists like myself, if I'll sort of put myself in the bucket, is we jump straight to like, let's have machines and robots do all of it. It's sort of maybe something to do from science fiction. It's kind of inspires that way of thinking. And so this idea that we're going to have, robot therapists come in and use the same skill sets and the same approaches that a person would use, a trained professional, a trained provider would use, and somehow help a person have better outcomes over time or manage their condition. I think while it's very appealing, my view on this, and I may be wrong, but it's also very challenging. And I think that there's I would say at least three fundamental challenges when I think of those coming in. And I'd be curious to hear your thoughts on if you agree or if you feel like there's a different view of it. I think there's a clinical efficacy challenge, which is not apparent that, at least to me, that you can have the same clinical outcomes when it comes to helping a person manage their PHQ-9 scores or some other assessment that's validated with these automated systems to the degree that you would with human support and human care. There's something about the human nature of that interaction. There's obviously a risk and safety component to it because of all the different scenarios of SI and suicidal intent and also things that can happen to mental health. And how do you design these kinds of AI systems or tools? And I think that's, again, partially unsolved problem. Maybe there's been some progress, for example, you have to share. And then the third one is this discussion on empathy, right? Which was for a very long time, there was this idea that empathy was the job of humans and machines would not be good at it. I think more and more we're sort of seeing research that says, what is empathy in an interaction? It's tone of voice, it's choice of words, it's body language, and we're starting to see these models, AI-based models, start to embody some of that. So I'm kind of torn about those three, but I think those are the three big kind of building blocks that I think are still some ways away for true kind of AI capabilities to come in and take the role of what is done by a therapist or someone who's working with a person.
Yeah, I like that. The idea that we're going to have autonomous therapists I don't think we're there yet,
Yeah.
although there's some great attempts at that with Limbic and Wobot and other companies. I think it's more useful to think about using AI to do the things that are really the kind of stuff that you don't need a human for. You may need a human for developing trust and developing, a sense of, we'll call it collaborative relating to a person who really needs that, really needs that kind of high touch as well as high tech. I just think it's so important when we have these conversations that we ask the question of AI compared to what?
Mm-hmm.
So if you're saying, is a bot going to be better than a master clinician with 30 years of experience and a great sense of clinical intuition and a brilliant talent for empathy and relatedness? Yeah, maybe not. But who gets that? Like, who actually in the real world gets help from a master clinician today? You're talking about the 1% or 0.1% of the population. Most of us are stuck um, getting somebody who has some training. They may be just out of training. They maybe are given 11 minutes to spend with us. I mean, look at the treatment of depression. It's largely done in the United States by primary care docs who have almost no training in mental health, have about 10 minutes to do an assessment, one more minute to write a prescription for an SSRI, and that's what you get. So I guess the question is, can we do better than that? Is there a way to build out tools that actually could help with the assessment of depression by listening to speech and voice and maybe using face emotion and maybe even including some sensor data to capture objectively what is somebody's mood state? Could we use the same kinds of tools to be able to know when somebody's getting better or if they're not getting better? So we create a feedback loop and we have what, people in this field call measurement-based care. I just think the current state of care is so abysmal that it's a little arrogant to say, oh, we don't want help from machines, or we don't really, we're so concerned about the risk here that we don't want to begin to think about what the potential promise could be. And I'm really concerned because I think that we have all gotten spooked by lots of wonderful journalists who have talked about hallucinations and, like everybody else, I love Kevin Roose, who writes in the New York Times and who is in this space. And I think he's captured some of the real concerns around what happens when these LLMs don't work.
Mm-hmm.
But look, I spend most of my time hearing about what happens when the world of mental health care as we know it in 2023 doesn't work. Just heard from someone this morning about African American kid discharged from the hospital way too early, wasn't well, shot by police, dead, a week later. That's the world of mental health care as we know it. And we can't accept that. I mean, we have to find a way to take whatever tools are out there, whether that's from the world of policy, the world of science, the world of biology, the world of social change and civil rights, whatever it takes to begin to get better outcomes. And so I don't think we're in a position to say, oh, this is potentially going to be a real violation of privacy. If it is, you'd have to look at that very carefully and you have to understand how does one anonymize and de-identify and create the kind of data platforms that we're going to need. But we need help here, and being able to provide some objective tools. I love this company, Ellipsis, that does this using voice and speech together.
Mm-hmm.
It just bakes that into every interview that a care manager has, so that if you have diabetes, the manager can know, oh, this person also has depression and needs to be treated for depression. 60% of people who have diabetes and depression, which is a lot of people, are never diagnosed or treated. And it's one of the reasons their diabetes doesn't get better. So we need this. We actually need something far better than what we've got now.
Yeah.
And some of these tools are really showing promise. So I think we're going to have to figure out getting the right framework for using them.
I have one question. This is great. I have one question on the actual AI piece, and then I want to talk about the bigger challenges in behavioral health because AI is just a subset of the bigger needs here. But why? I mean, you and I have been both sort of involved in some of these, passive sensing approaches for the last, I'd say, decade plus. I mean, some of this was work I did for my PhD back in the day, using your smartphone as a diary of your life. What's holding back the incumbent healthcare system from really adopting and leveraging these technologies, Tom? Like, is you, in your view, and I'm happy to share my views as well if it's relevant, but I'm kind of curious. The technologies are promising. There's certainly some pockets where we've seen adoption, but if we think of large scale adoption of these capabilities, it feels like we're not that far away from where we were 5 or 10 years ago, even.
Mhm.
And I mean, maybe you disagree with that, and that would be interesting to hear. But if you agree with that, I'm curious to hear why are these technologies, at least on the assessment side, which have been around, or the models have been around for quite a while, what's holding broad adoption?
Yeah. So I think I guess there are two or three reasons. One is I would say healthcare, particularly mental health care, is remarkably allergic to innovation. It's very hard to get providers to change the work stream and to begin to do something new.
Yeah.
The second is that it's been, I think, quite difficult to get payers engaged in wanting to see these tools scale in any way. There's some interest in it, but I think it's been hard for them to see the economics play out in the right way. And to be fair, even there are patients who are a little reluctant. There are lots of stories I can tell here, but I think maybe two stories that are really relevant to me and the way I've been thinking about this. When I was at Mindstrong, where we had something very similar to what you were doing at Ginger, we had basically a way of using smartphone signals to detect depression early and really help on the diagnosis of depression. I pitched that to the chief medical officer at the time at Kaiser Permanente, and his point was like, why would I want this? I don't really want more data, even if it's good data. You're showing me essentially a smoke alarm. I need a fire extinguisher. So what I need is, help with a workforce that's way underpowered, that's really overwhelmed. Anything that's going to cause them to spend any additional time on anything, it's not going to happen for us. So save us time. Don't give us more data. So I think that on the provider level, we really have to figure out, how do you demonstrate that this solves a problem for providers? Does it really save time? That's why I'm so focused on the idea that using GPT-4 or one of the other LLMs, you can actually get reports written in real time. And instead of, in the California setting where I am, in our public mental health system, our community health workers are spending 60% of their time documenting what they do, the other 40%. We could essentially double the workforce if we simply get rid of that. We have an automatic way that a document is written at the end of every interview. Boom, done. You've doubled the workforce. That's a pretty powerful selling point. And I don't think we've yet demonstrated that, but I think as that becomes evident and you prove out the accuracy of these things and their efficiency, I think you'll get adoption. But we have to show that, and we have to get people willing to do that. That's going to happen.
Yeah.
The other story, which is really kind of blows my mind, it was one I heard just last week in a session I was doing on AI, that there's a company called Simple Practice that provides kind of back-end business stuff for a lot of private therapists. So psychotherapy is, unlike healthcare generally, is largely a mom and pop individual practitioner working in a private office, taking fee for service, kind of out of pocket pay. Some of them take insurance, most of them don't. But they use Simple Practice to help with scheduling, to help with billing, to help with kind of all of the operational stuff in an office. And Simple Practice has really taken over that field. It's a huge company with a huge service and a lot of popularity. Sometime recently, Simple Practice, the story I heard was they suggested that they were going to start to use some AI tools. And for that, they wanted to capture the individual interviews, anonymize and de-identify them, but to use the data to generate the algorithms and the training on creating essentially a dashboard that would help therapists to become more effective. And that just created a firestorm. Like, people were saying, no, you can't. I don't want you recording anything I do. This is from providers, not patients. So I think there is a real barrier to adoption. There's not an appetite for innovation. There's actually an allergy to innovation from a lot of people who are on the front lines of this field and who are comfortable doing what they've been doing a long time and don't want to change that in any way.
Yeah.
It's odd because those same people would be willing, I think, to drive an electric vehicle that's got lots of AI powered features to it, but they just don't want to change what they do in practice.
Yeah, no, I think that's a really great point, and I think this brings me to, I think you had a recent article a few months ago about lessons from Act One of mental health care and what's to come from Act Two to Five. That I thought was a great roadmap or way to think about the future.
Mm.
And one of my big takeaways from that discussion, Tom, was that the technology, AI components. I mean, that's just a part of the actual challenge, right? There's a lot more which you started to hint at, which is the culture inside mental health and the mental health community with providers, with practitioners, the social kind of factors at play, the regulations, the way things are structured, the incentives, the economics of healthcare. And would it be fair to say that those are perhaps a much bigger component of when you think of what's holding back some of these capabilities in behavioral health? Or how would you sort of put those in context and maybe spend a few minutes on the bigger picture there?
Yeah, well, it is a big picture and it's a complicated picture. And I think there's a lot of other stuff to be solved besides simply creating reports and providing summaries or translations, which is another huge thing that AI does so well. And I got to say, I don't know whether most people have used the tools, but they are awesome in what they can do. It's really fun to take these out for a test drive. But when you think about the mental health crisis as we know it in America, increasing rates of suicide, new numbers are just out, higher than ever. All the problems we have with the criminal justice involvement and the youth mental health crisis and a massive amount of addiction deaths that we're dealing with. I mean, those are not going to be fixed by, there's like no magic bullet. AI is probably a piece of it, but it's much more high touch than high tech for most of this. And the world that we need to think about, I think, is a world that really looks at changing policy, maybe more than just information flow. So they're just huge issues around what we pay for, what we incentivize in care, how we engage people in care. I wrote that piece about, that we're in the first act of a 5-act play because my point was, I think digital mental health is really promising, super exciting. There's a lot happening. And in many ways, it's begun to democratize care in a way that we couldn't have imagined 5 years ago. But I think it's been more about access and less about quality. And if you really want to change those big public outcomes, the population health issues, you got to look at quality. You got to improve the quality of care. It's not just getting more people into crappy care. And so there are issues around how we do that. My belief is that technology can help improve quality by doing things like, it's a great place for AI. You can create training programs with basically AI-driven virtual patients that people can learn on. You can create accountability measures and start to measure in real time whether people are getting better or not, and create the feedback loop like we have in diabetes and hypertension and many other areas. And that's the beauty of some of the voice and speech biomarkers, that it actually provides those objective outcomes. So there's a lot you can do, but it's really got to be in the service of, I think, improving quality, improving accountability, improving what I'll call generally equity. That is, moving beyond just healthcare in its sort of formal way, but thinking about, I call it recovery measures for mental health. And that's more than symptoms. I use the 3 Ps a lot, the people, place, and purpose. And there's not an AI solution for that. Social support, having a safe environment, making sure that people aren't homeless, and making sure that people have a reason, a purpose, a mission. It's really important in mental health care to help people engage on something that's deeply meaningful to them. And, in the same way that I think we've for too long thought there's going to be a pill, there's going to be a magic bullet in the form of a pill that can do a lot of this. Now we tend to be thinking about, if we just have the right software, just the right algorithm, once again, there'll be another magic bullet. It's not that easy. You need medicine, you need algorithms, you need a lot of stuff. And it's all got to come together in a way that actually solves the problems that you need for people who have some pretty complicated illnesses, often complicated by environmental factors that we don't engage enough when we're trying to do straight healthcare.
Yeah, that's a really thoughtful viewpoint and something that I think we all have to remind ourselves on the technology and AI side of the bigger challenges when working and applying these tools to healthcare. We sometimes are guilty of, starting with the solution versus starting with the root cause of the problem. At least as technologists, it's a lesson I try to hold dear to heart.
Yeah.
Well, Tom, thank you so much again for carving out the time and talking to us about your vision for where AI can play a role in behavioral health, as well as the macro challenges in behavioral health today.
Delighted to be here, Anmol. Thanks for having me.
Once again, this is Anmol. I'm the host of the Autonomous Health Podcast. Have a great day, everyone.